Hello everyone and welcome to today's webinar, Trauma Verification's July Q&A Web Conference. For best sound quality, we recommend joining today's event through the telephone. You can find dial-in instructions on your control panel when selecting telephone. If you encounter any troubles during the event, please reach out via the chat option in the control panel as well. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Hi everyone, thank you for joining today's web conference. And I have a few disclosures that I'm going to go over. So today we have myself and Rachel presenting. So the goal for this webinar is to interpret the standards outlined in the resources for optimal care of the injured patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. And understand the process and standards involved in the ACS, in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your center. So with that said, let's get started. So for this webinar, if you have a copy of your resources manual, that will be great and handy. If you do not, you can download a copy as a PDF from our website, and I also would like to say that you can download, or you should download, a copy of the clarification document from the website that's here that goes along with the resources. So any changes that were made to the standards during the year or since the release of the manual will be posted on this clarification document. I do want to add one thing that we will be releasing or posting at the end of this week, which is a change log document that is going to be similar to that of TQIP and NTDS. And again, that is going to be up on our website hopefully by the end of Friday, and we hope that that will be a great help to a lot of trauma program managers, and trauma medical directors going forward. So we'll keep that as a live document with any changes. The clarification document will still be on our website as just as a point of reference, but we'll also add the change log as well. So I also want to add that the recording of this webinar will be posted on our ACS YouTube channel at a later date. We do have last month's webinar posted, so you're free to listen to that webinar at your convenience. All questions are pulled directly from the questions submitted via the webinar portal. There have been no edits made to the content or misspelling, so what you see is what was submitted to us. We'd like to keep that framed. In your question, if your question is not answered today, the question is either a duplicate or requires more information, and will receive a response from me within a week after the webinar. So I will follow up with folks that questions are very specific to their trauma center. Any unanswered questions will be answered within a week after the webinar as well. So with that said, I am going to pass this on to Rachel Sanchez.
Good afternoon, everyone. I'll jump into the first question here. It's in regards to site visit application. The question is, for both adults and PD verification, is there only one application to fill out, or are they separate applications? And this is coming from a level 1 center. For a concurrent level 1 peds and a level 1 adult site visit, although they are considered two separate visits, just one application is required. However, please note that separate PRQs will need to be completed. And you can see where to find the site visit application at that link. Okay, the next question reads, when applying for a level 2 pediatric center, how many charts are required for review? And this is coming from a level 1 center. So you'll want to refer to page 7 on the review agenda. There's an outline of what cases will be required for the pediatric trauma centers. The number of cases will vary per center due to the volume. For example, in an adult trauma center, the number of charts pulled typically equates to about 120, but for a ped center, the volume is usually less. And then again, you can find the review agenda at the link at the bottom. Okay, the next question reads, what protocols and policies are required or recommended to have for the review. So it's recommended that all hospital policies and or trauma protocols be kept in a binder and labeled accordingly and should be available on site for the review team. And this information will be added to the review agenda within the next week.
And I would like to also add that I know some of you have gone through a site visit, and sometimes the types of documents or cases that are presented vary based on what the reviewer prefers at the time of the site visit. So that, again, is going to vary. But anything to do with policies, transfer agreements, transfer contracts, I know everybody uses the words a little differently, just have those in a specific binder, and the review team will go ahead and review those when the time is appropriate.
Yep. Okay, so the next question is in regards to the PRQ reporting year. And it reads, if our site visit is in January 2017, what is considered the reporting year? PRQ would be turned in around October. In the review agenda, at the bottom of page 5, it reads, the medical records must be pooled for the reporting period and should not be older than 14 months prior to the scheduled survey date. So if your visit is in January 2017, you'll just want to count back 2 months. And like, for example, since your visit is going to be January 2017, you could use October 1st, 2015 to September 30th, 2016, or you can use the November 1st, 2015 to October 31st, 2016. And then as for the PRQ, it must be marked complete 30 days prior to your January visit.
Okay, so we're going to get started with general questions. This question about FAST exams came up for this webinar. So the question relates to credentialing for FAST exams, and there really is no formal process that the ACS or the verification process is asking to be done. That is going to be defined by the institution. So some hospitals have a formal process, and what we expect is a trauma program has some input into that process and credentialing their providers. So again, that's going to be defined by the institution. I put this back in just so folks can get an idea of what the FAST exam QI looks like. Again, it's just if there's any findings from a FAST exam, that there's regular meetings held by the emergency director, and that information is passed on to the trauma medical director for any performance improvements that need to be done. And the question also asked, site reviewers will look through the case reviews for cases that FAST exams were performed on. Some reviewers are very specific in looking for that. Others are not so much, so they will pick that up during their case reviews. Question about staffing. I've been seeing this come across this week or last week. So the question is, how many trauma physicians are needed for staff at level 2 and level 3 trauma designated facilities? How is that number derived? And this came from a level 3 trauma center. So as many folks know, this can vary significantly from a level 1 to a level 2 to a level 3. So there's not a finite number. This number, again, is going to be derived from the level, the type of facility, if it's, you know, an institution where there's residents, and if there's not residents, and especially it's going to, let me frame that again. It's going to depend on the trauma center and the level. There's a list that I'm going to show which is not inclusive, so this list is probably bare minimum, and as many of you know, this list will be much greater than this. And if it's a pediatric trauma center, there's additional staffing that's going to be needed for the pediatric trauma center as well. And I did not put that on the slide, but I do have that available. So if anyone is interested in having that additional information, I can provide that after the web conference. The rest of the webinar is going to be based on CD-related questions, so we'll move on to that. So I'm going to spend a little time, not a lot of time, but a little time on CME. I've got a lot of questions about this, and it comes up frequently. not only in emails but also in our courses and in our webinars. So internal education process, it does vary for a lot of trauma centers, so hopefully I provided some examples in this webinar that folks would be, can share or use and tailor to meet their needs. So the question I received was, for a level 2 pediatric trauma center undergoing first-time verification, is the use of internal education, such as a newsletter with hour-for-hour equivalency, advisable as a surrogate for pediatric trauma CME for non-liaisons? So these are everyone else other than the liaisons. And the adult pediatric general surgeons taking trauma call other than the pediatric trauma medical director. Or would the ACS consider the standard use of CME certificate for first-time verification as a better approach? So it's a long question, and I just want to say the expectation is that during a site visit, the center has to demonstrate what mechanism is being used to track the internal education process. As I mentioned, that varies greatly across many institutions, and that documentation and how you're tracking that documentation and who's attending is what the site reviewers are going to want to see. So again, hopefully I provided some examples here in a couple of more slides. Due to our monthly multidisciplinary and peer review meetings count external CMEs if we provide AMA primary PRA Category 1 credit. That is not the ideal CME that we're looking for when it comes to verifiable external CMEs. What we're looking for in external CMEs is for your liaisons and trauma medical directors to attend state, regional, national conferences or online courses. So if they attend EAST, AAST, trauma critical care, those are the kind of CMEs that we are looking for when we're speaking about external verifiable trauma CMEs. And this is going back to who must accrue CMEs. It's the medical director and liaison for emergency medicine, neurosurgery, orthopedics, critical care, and they must accrue an average of 16 hours per year over the course of 3 years. So it's a total of 48 for the 3 years. The other trauma panel members, which we refer to as non-liaisons, they have to either do the external CME or they can do the internal education process. And anyone who is new to the service, new to just out of residency, their CMEs are going to be prorated. So a little bit more about internal education process and what it should look like. Here are some thoughts on what it can reference. So quality issues identified at your peer review, systems meetings, or nursing and physician chart audits. It can be based on regulatory mandates like the Joint Commission, pain assessment, flaws, medication, etc. The list is endless when it comes to that. It could be evidence-based practice through journal or national meeting information. You know, anything that's reviewed through the PIPS process, you know, that is something that you want to use to educate your non-liaisons, your nurses, or any other staff member. The expectation, again, is that you must be able to document the activity, track the activity, and during the site visit, demonstrate that that activity is actually being done. One of the things that is in the Orange Book, we talk about how the internal education process has to be equivalent to 16 hours of CME, and I just want to stress that we're saying a should. We want it to be to equal CME hour for hour. Again, you know, it's a should, it's not a must, and just keep that in mind. Here's an algorithm that we developed with my RSTN partners. It helps kind of identify who needs CMEs versus physician education requirements and non-liaisons. This is also on our website. The link is at the bottom. You can use this kind of to drive how this is going to look at your facility. I also want to state that CMEs actually can, for the non-liaison, CMEs can be either external or internal. What I like to express is that you have some kind of documentation that details what's going to be external and internal based by the course that is being presented or how many hours of trauma that course provided, or if it's an internal education process, what platform did you use, what content did you use, and how was that disseminated and used. Again, internal education process, this is in the book. You know, it can include case-based learning, educational conferences, grand rounds. This actually is contained in each chapter, each surgical chapter, including the emergency department chapter. So you can go ahead and refer to that chapter. Here's a quick checklist that I created, and I do want to say that I am working with the Informatics Committee with some team members here. We're going to develop, or we have developed, a survey that is going to go out to all the trauma centers who are verified and those that are not verified. We're going to send this survey to inquire how trauma centers are doing IEP at their facility. And here are a couple of questions that we actually took from just things that I see on a day-to-day that people have asked and what we're going to put in the survey. So again, determine what platform or program is going to be used. That can be SharePoint, SurveyMonkey, Intranet. I mean, any kind of platform that it has the ability to have the documentation and send it and track it and provide some kind of report for the site reviewers to see. Define the subject matter, whether that comes from national conferences, local, peer review articles, a webinar or course. You know, it can be from any type of course-related content. How often is the IEP utilized at your facility? Do you do it weekly, bi-monthly, monthly, quarterly, etc.? You know, just the most important thing is that you're tracking this. You're able to prove this at the time of the site visit for the reviewers. And I'm going to move on to trauma peer review. Again, there's a lot of questions about trauma peer review. We've done some changes in this area. For this one, it's related to pediatrics. So the question is, we're an adult level 1 with pediatric capabilities, currently in the process of becoming a pediatric level 2. We hold this meeting monthly after our audit, M&M meetings, and have all of the panel for the adult trauma service attend. We use pediatric surgeons from another institution. Can one pediatric representative, whether the medical director or another pediatric surgeon, represent all, or do we need all pediatric surgeons to attend 50%? And is a PA for the service acceptable? The intent is, if it's a combined adult and pediatric verification, the expectation is that the surgeon from each specialty, adult and pediatric, attend 50% of those meetings. That is a requirement. So all trauma surgeons must attend that, and the liaison. There was a recent change that it could be a designate for the liaisons. It could be a dedicated representative, the same representative over time. It can't be one different each month. It's got to be the same person. They can share that 50% attendance with the liaison. Unfortunately, PAs cannot be an alternate to meet that requirement. Question about, can one representative from anesthesia or radiology count for both the adult and pediatric representatives for this meeting as we combine this meeting for peds and adults? Because there's very few anesthesia and radiology staffing, we said they can share adult and peds, attending the adult and peds committee meeting. So yes, they can do this. What I do want to stress is that if you are a combined trauma center that is holding these meetings concurrently or on the same day, there must be separate minutes and separate start times to define the adult meeting from the pediatric meeting. So I just want to make that clear, that there has to be a separation between the adult and the pediatric minutes. The TMD, so the question also talks about minutes from the meeting. Is that acceptable if they don't attend? Unfortunately, it is not. They have to be present. One of the alternates to not being present is that they can video conference in or they can teleconference in, so they have that option to do one or the other. More questions about trauma peer review meeting, orthopedic liaison requirement. Can this be a shared position among orthopedic surgeons? So the response is the liaisons, orthopedic surgery, neurosurgery, emergency medicine, ICU, et cetera, and it designated one predefined person, again, one person in name, can share the attendance at the trauma peer review committee meeting. So the answer is yes. Peer review meeting attendance requires 50% for TMD and trauma liaisons, but not for the rest of the trauma surgeons. I'm not really sure if I'm misunderstanding this question, but the requirement is for the peer review committee is to encompass the trauma medical director, trauma surgeons, and all the liaisons. And again, the liaisons can share that with an alternate. Locums, a trauma peer review committee, and locums in general. I do want to disclose that if you are using locums, the expectation is that they have to meet the same requirements as any of the other trauma panel members. And this question comes from, would a trauma attending who covers trauma call only 2 days in 3 months need to attend trauma peer review 50% of the time? Second question is, would ensuring that the above trauma attending receives monthly updates about peer review from the TMD counselors at 50%? As I previously said, they have to be in attendance for it to count, either video or teleconferencing or in person. Those are the options at this time. Locums or trauma surgeons who take partial trauma call are required to meet the 50% attendance requirement. An alternate of the attending, again, video or teleconferencing. Question about pediatric care. What is the best way to meet CD 2-23 in the Orange Book? Credentialing a trauma surgeon to care for pediatric trauma care. So this is going to vary by the institution. So ideally, the trauma medical director is the one that is going to credential that person, and that, again, would be that the trauma surgeon is, or the pediatric trauma surgeon, or the trauma surgeon caring for pediatric children have skills and expertise in treating kids, and that they're board certified if that's what the hospital bylaws require. And that, again, you can expand on that at your institution. Question about transfers. How track patients diverted from HIPAA violate to share data unrelated to care and unknown what they went to city other level 2? I know that's not completely clear, but I think it's referring to if the center is unable to obtain data from the transfer facility, document that an attempt was made but was unsuccessful. So what the reviewers want to see at the time of case reviewing these cases is that there was an attempt. If it's not documented, you can't just say that it was done. It has to be documented, and if you can't get that information, just let the reviewers know and chart that. Transfer agreements. What is needed to show transfer agreements at a level 1 trauma center? Again, we use the word transfer agreements in the Orange Book, throughout the Orange Book, as a matter of fact. Some facilities use the word contracts. It's interchangeable for us. We're not, we don't have a preference over one word or the other. What we want to see, or what the reviewers want to see, is that there is a signed agreement contract between the trauma center and the receiving facility or the transfer facility, whichever case you're at for this. And those transfer agreements vary through the book. Again, transfer agreements for specialty care, rehab, bypass, divert, etc. I know Rachel touched a little bit on that during her presentation about the review agenda. So we are going to add some more information about that in the review agenda over the next week. Question about trauma team activation. CD 515, level 3. How would 10, the question here is how to document that the trauma center is in compliance if there are 10 members on the trauma team? What is the threshold? So for a level 3 trauma center, the threshold is 30 minutes. Again, for a level 1, level 2 is 15 minutes, level 3 is 30 minutes. So there has to be evidence of a system or a process that captures each of the trauma team members' response within the time frame. So again, 1 and 2, 15, level 3 and 4 is 30 minutes. The following slide provides some examples that we have. You can, if you have a scribe that's capturing all the response times, you can document that in this a similar documentation that is here, or if you have a key swipe, obviously that's ideal, but not every trauma center has a key swipe. You can run reports if there is a key swipe. So that's the easiest and obviously the easiest way to report that, but obviously you can use a documentation, a document that captures all that information as well. Lots of questions about same level falls and isolated hip fractures. I know there is some inconsistency in our clarification document and our PRQ. In the PRQ, it does talk about not including that. I will address that and I will fix that going forward. So the question is, what is the current stance on same level falls / isolated hip fractures? Do we not include them in our registry? Others do. This is from a level 1, and again, this can be a level 1, level 2, level 3. It makes no difference what level it's coming from. So the expectation is if these patients meet the NTDS inclusion criteria, they should be captured in your trauma registry. And if the center includes them in the volume and admission numbers, mainly for a level 1, but if a level 2 also uses them, or a level 3 on the PRQ, then you must follow the rules of any other trauma admissions, just similar like non-surgical admissions. So if you're treating, we treat those as similar to non-surgical admissions, you have to PI them. So refer to CD 518 in Chapter 16, and it's also in Chapter 5. It breaks it down on how to look at those non-surgical admissions. Now, I do want to state that this may differ from your state inclusion criteria. If it does, you may have to capture 2 sets of data points. So just keep that in mind. If you're in a state that requires a different type of inclusion criteria from the ACS, you're going to have to capture 2 sets. For verification purposes, we're looking for the ones that meet the NTDS inclusion criteria. Trauma surgeons and backup call. So a question came in from a level 3 trauma center. So they have trauma surgeons who simultaneously take call in the same community at 2 facilities. This has not been cited as an issue during a consultation visit or verification visit for either facility. It is WATS and PIPS, backup schedules for both centers. They have 0 issues in the last 2 years. Is that acceptable? It is acceptable. At a level 3 trauma center, it is acceptable for the trauma surgeons to cover another level 3 trauma center. Level 3s are not required to have backup call schedules, so for this particular trauma center, that is acceptable. ATLS for emergency physicians, CD 7-14. Must all ER physicians have ATLS, even though ACEP is recommending they don't? This is coming from a level 1. I will do some follow-up on this. ACEP recommending they don't. I've not heard this, but I do want to state that verification requirements supersede anything that ACEP has established unless it's documented in our clarification document. And this is not one of those areas. So for a level 1 trauma center, and this is the same for a level 2 and a level 3, the requirement is that all physicians must be board certified in emergency medicine and or pediatric emergency medicine and must have taken ATLS at least once. Level 3s have, ideally they have emergency physicians who are board certified in family practice, internal medicine, and they have to be current. So if you have physicians who are boarded in internal medicine and family practice, they have to be current in ATLS. That's the difference. Neurosurgery at level 3. Could you go over the neurosurgery requirement for level 3? I was confused by the last webinar. We have neurosurgery coverage and a backup call schedule, and we'll divert these patients or quickly transfer. For some reason, we can't get neurosurgery here. Covered by PIPS, no issues. What is the dynamic that was mentioned whereby level 3 centers are essentially level 2 centers if they have neurosurgery capabilities? So I do want to clarify that. So we're seeing, so let me respond to that. So level 3 trauma centers that have neurosurgeons that are carrying and keeping neurological patients for TBI, ICP monitoring, etc., are expected to meet the same requirements as a level 2 as outlined in Chapter 8. We're not referencing the entire Orange Book, we're referencing Chapter 8 that excludes CME. So there's a lot of level 3 trauma centers out there that now have neurosurgeons on call, and they're treating these patients for ICP monitoring and TBI. And if they're keeping the patients and they have the equipment, they have the capabilities, the expectation is that they meet the requirements outlined in Chapter 8 that is similar to a level 2 with the exception of CME. If it's a level 3 trauma center that has a single neurosurgeon or has credentialed a trauma surgeon to care for that neuro patient, to maybe put a burr hole in and stabilize and ship them, the expectation is much different. We're just asking you to meet the 4 elements that are captured in Chapter 8 for a level 3 trauma center. So there is a distinction there for level 3s. Again, we're seeing a lot of level 3s with neurosurgeons and keeping those patients and having the capabilities similar to a level 2. Credentialing process to allow the trauma surgeon to provide initial eval and stabilization of the neurotrauma patient. As I mentioned, there must be a plan that is formalized that may include training and credentialing of the trauma surgeon for initial stabilization. That could be, doing burr holes, and initiate transfer to another center of the same or higher level. If you are this level 3 trauma center that is doing this and only doing this, this is an ideal situation, then these occurrences must be monitored by the PIPS process. Neurosurgery backup, is a backup on-call schedule for neurosurgery necessary if they are only covering one hospital. It's not required to have a backup call schedule. The ideal thing to have is a contingency plan where if the neurosurgeon is encumbered, if another trauma alert comes in, that you have this contingency plan to stabilize and or divert the patient to another facility. You can refer to this on page 54 for what specific requirements the contingency plan needs to have. Orthopedic surgery and neurosurgery question about, can you please clarify the orthopedic and neurosurgical response to a trauma patient? Who can do the evaluation of the highest? And this is coming from a level 1 trauma center. Orthopedic surgeons and neurosurgeons must be available in the trauma resuscitation area within 30 minutes of notification by the surgical team. So if it's, so they can certainly send a PA or a resident. What we're looking for, what the site reviewers are looking for during the site visit, if you're going to send a PA or a resident from ortho or neuro, that there must be clear documentation with the attending orthopedic or neurosurgeon on the plan of care. So that has to be clearly documented. So yes, a resident and a PA can definitely respond. There is, you can refer to the clarification document about that. Anesthesia CRNAs, 11-5. Can the in-house anesthesia requirement for level 2 be met by having CRNAs with MD on call? This is coming from a level 2. So the answer is for a level 1 and level 2 trauma center, when you're using CRNAs or a senior resident, or we also have the certified anesthesiologist assistant for states that use them, if they're used to fulfill the availability, the attending anesthesiologist must be advised, and she must still be available within 30 minutes and present for all operations. So they're technically on call, but they have to come in when they're asked to come in, and that has to be tracked. Operating room, CD 1115. If the first OR is occupied and adequately staffed, additional room must be available. Please elaborate on the staff. And I'm not sure what partial means, but I think that's just a typo. There has been some confusion, so I will state that first. There has been some confusion on this with the staffing of the OR and the anesthesiologist. So the response is that the anesthesiologist does have 30 minutes to respond, while the OR team within 15 minutes preps the room and the patient. So it kind of gives them a lead time, and then the anesthesiologist has 30 minutes to respond either from in the hospital or outside the hospital, but it helps that they do that so that the patient is prepped, and when the anesthesiologist comes in, that they can begin the case upon their arrival. And again, all that has to be documented in through the PIPS process. ICU coverage, CD 1148 and 1149. Our TCI trauma ICU is covered by PGY2 residents 24/7. A trauma team with PGY5 and trauma attending is in-house. Is this adequate coverage at a level 1? Yes, that is acceptable. The team is going to be comprised of various specialties and residents. The expectation is that they are surgically directed by a trauma attending who is board certified in surgical critical care. Again, that's for a level 1. When I say boarded in surgical critical care, pediatric level 1, they do not have to be board certified in surgical critical care. Again, refer to the clarification document for more information on that. Microvascular surgery, hot topic. If microvascular is a regional asset that is readily available but not performed at our level 2, will this be a CD? Not having it performed at the level 2 is not a CD. Not having a microvascular surgeon or a surgeon who can do microvascular procedures with the equipment is going to be a CD. So a microvascular surgeon must be available within a predetermined time of notification by the surgical team. So the institution is going to define what that predetermined time is to respond. So they don't have to be in-house, but they have to make themselves available when they're consulted. So patients that require specialty care, such as replantation, may be transferred. Those are the cases that should be transferred out, and that must be reviewed through the PIPS process. But any other types of microvascular procedures that a level 2 has the equipment to perform, it is expected that they have that, that they meet that. Otherwise, it will be cited as a deficiency. Question about thoracic surgery. Our thoracic surgeons required of trauma surgeons manage most of thoracic trauma that arrives at our level 2. A thoracic surgeon must be available within a predetermined time of notification by the surgical team. So same as microvascular surgery, if you have surgeons on your trauma team, they can perform this procedure and they're credentialed to do so and have privileges to do so, that is acceptable. As long as, again, that is agreed upon within the trauma panel, trauma medical director, and the thoracic surgeon. Other surgical specialists. Is a level 2 facility required to have hand microvascular, vascular ENT, OMFS, and plastic surgery coverage 24/7, 365 for a level 3? Not for a level 3. For a level 1 and 2 trauma center, those specialists must be available at all times with a predetermined time of notification by the surgical trauma team. Again, predetermined time defined by the institution, but it's not required for a level 3. Advanced practitioners. Lots of questions around this. I am going to add another clarification to this in the clarification document, and it's going to read as it does here. So the question asks, do advanced practitioners in the ED have to current in ATLS, or can they audit the class with no fast track? Can advanced practitioners in ED do the initial assessment if audited ATLS, or should the ED physician? So what I'm thinking they're asking here is that if they're working fast track, do they have to be current? No. So if your PAs or APPs are working in fast track or doing the consultation or doing the evaluation during the consultation level, they are not required to be current in ATLS. The change or further clarification is going to read as follows. The trauma and or emergency departments mid-level providers that function as a member of the team caring for trauma activation patients via assessment or interventions must be current in ATLS. If the trauma and/or ED mid-levels or APPs, we're going to change that terminology here, only role as a scribe or entering orders, they would not need to meet the ATLS requirement. So again, if they're part of your level 1 or level 2 tier activations or high tier, mid-level tier, and they're hands-on with the patient, they are required to be ATLS, current in ATLS. If they're scribes, order taking, pushing the gurney in, if they're not hands-on, they do not need to be current in ATLS. Burn patients. Question about burn patients. Isolated burn-only patients at hospitals with internal burn program, should they be excluded from trauma volume? This is level 1. This is going to depend. So if it's a burn patient who are treated by the trauma service and who meet other inclusion criteria, such as length of stay, should be included in the trauma registry. So if it's a poly trauma and it's a burn, certainly they should be counted in your trauma population. If it's a burn patient who has just external burns, they should definitely just be transferred to a burn service or to the burn center. So burn patients who are transferred externally to a burn center, internally to a burn service, should not be included in the trauma population. This is also in Chapter 14 in the Orange Book. Sorry, I didn't have a page number on here, but it does talk about that in that chapter. TQIP benchmarking report. So a brief overview on TQIP and its role with level 3 trauma centers and site visits. This is coming from a level 3 trauma center. So since level 3 TQIP is new starting this summer, a summary of your TQIP report would not be available to the review team until the data has been submitted. So let me expound on that a little bit. So if you're a new trauma center that was not in the pilot but is just new to TQIP and you have a visit this year, there may not be a report available at the time of your site visit. So, so really there would be no benchmarking to compare yourself against for this year. But if you're in the pilot program, there may be some data there that the reviewers will have. So again, we're providing a summary of the TQIP report to the site reviewers, but you can certainly reach our TQIP lead on this for more information, and I can provide that information after the web conference if anyone's interested. TQIP Level 3, at what point would a Level 3 facility in the process of going to a Level 2 begin to submit to TQIP? If the center has a signed TQIP contract, data can be submitted shortly thereafter. For example, I had this actually come up recently. If the center is scheduled for a re-verification visit as a Level 3 trauma center and has signed a Level 2 TQIP contract, they can begin submitting data, and that will not impact the verification visit. So just because they're being verified as a Level 3 and has a Level 2 contract, it's not going to impact the verification process, and it's, you know, you're meeting the requirements of 15-5 that you are enrolled in TQIP. More questions about TQIP. This is a typo. It should be CD 15-5. Can TQIP requirement be waived if a current benchmarking program is in place? Such as our, I think this is Lonsdale Regional Medical, the Joint Trauma System in Texas. This is a Level 3. This will vary. So for instance, if the center has a site visit scheduled prior to January 1st, 2017, the center must demonstrate that it is enrolled in a risk-adjusted benchmarking program. If you have provided that information on your site visit application, the TQIP office team will verify that, and if there's any questions or concerns, they will contact you for that. Effective January 1st, 2017, for any centers that are having a visit after that date, all trauma centers must be enrolled in TQIP. So that is a change in the requirements, that is in the clarification document, and that is also going to be in the change log. Our registry question, CD 15-6. Trauma registry should be concurrent. At a minimum, 80% of cases must be entered within 60 days of discharge. CD 15-6, when referring to entered, the chart needs to be completed and closed to meet this. The cases must be entered and closed. This includes any cases reviewed through the PI process. So the answer is yes. Registrar question CD 15-9. If the registrar FTE requirement being reviewed, is the registrar FTE requirement being reviewed based on the use of ICD-10 and the additional time needed for coding? This is from a level 2. The current standard for 1 FTE for every 500 to 750 was based on the additional time needed to code and capture NTD, and TQIP data points. I will say that we have a work group that will be looking at all our standards for the next revision of the Orange Book or whatever color that may be. So we do have a work group that is going to be looking at each of the essential criteria to ensure that there is evidence-based data to support that requirement. So, so there will be more to come about that, and that kind of references this slide here. Has there been any consideration by the COT VRC committee subcommittee to review the registrar FTE requirement based on the use of ICD-10? And again, we have a work group, a PI work group that is working with the VRC, TQIP, and PIPs that are going to look at all the essential requirements, and a lot of these standards may change in the next iteration of the resources book. So it's going to mandate that there is evidence base to support that requirement. Question about rotations in trauma surgery. Does continuous rotation in trauma surgery, CD 17-3, require a senior resident rotating every month or rounding every day? And the answer is continuous rotation is defined as every day. I think some people have them rotating. It varies from month to month, but continuous means that they're there every day, 365 days, not every single day, but 24/7, 365 is defined, is continuous for us.
Thank you, Molly, for everything. This is Andrea. I'm actually one of the education coordinators here with our trauma department, and I realized that we've been offering CE at our new VRC webinars, but we haven't really talked about the follow-up to that. So I just want to let everyone know that we will be pulling the attendance reports of everyone who attended the webinar today, and then this afternoon we will actually reach out to everyone by email from the COT VRC email address inbox. We'll be sending out information on how to claim CE. So look for that email from us for everyone who qualifies. And as always, if you have any questions or concerns about continuing education contact hours that you've received from us, or any other questions about this webinar or other trauma verification education, don't hesitate to email us or give us a call. We're always here, and we're always happy to assist you and make sure that you understand everything. All right, thanks so much.
Thank you, Andrea. And I also want to add to that during the next monthly webinar Q&A, we did add a data field there to capture what level the questions are coming from, because I do understand that the answer can vary or differ if it's a level 1, level 2, level 3. So thank you for those of you that was using that data field. It is very helpful. And I do apologize if some of the questions that you see on the webinar are not clear. And if I misanswered or did not answer that question, please feel free to reach out to me at the COTVRC@facs.org email address, and I will definitely clarify that. And if there's anything that you all feel that needs to be brought up again at the next month's webinar, please feel free to do so. You can send me an email or do it via the webinar portal. Either way, we'll go ahead and capture that information. So thank you for your participation, and I'll see you all, or I guess, yeah, we'll see each other next month. Thank you.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's July Q&A Web Conference. If you have any other questions, please contact cotvrc@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.